request we will do for ourselves. Okay, we all know that. But for a bedbound patient, just imagine they need to do something, but they can't. So for a paraplegic patients, they don't want to do the oral care, but they are not able to walk. They are in bed, so they need a help. If we give the articles, if we prepare the articles and arrange the articles and give nearby to him, definitely he can able to do his own oral care. But if they are not able to do it, so ourselves also you have to, we nurses, we know we how to give an oral care, but we need to train the caregivers. If or that unconscious patient in the family, how they need to do the oral care. So that all things we need to teach. And skin care, eye care, ear, nose care, hair, perineal care, nail care. So these are the basic needs of a person and a patient. Coming to the oral care, so oral care is equal to overall health, because 80% of health related issues are linked with oral health. Because if you don't give a proper oral hygiene, oral care to the patients, they are more prone to develop systemic infections. So what are the purpose of oral care? We all know that mouth is an excellent incubator for growth of bacteria, because the food particles left in the mouth all the times, if they are not giving proper mouth care, there is a chance of bacterial growth in their oral cavity. And then the purpose is remove food particles. If you give a oral care, we can able to remove food particles from the oral cavity. So that is the medium for bacterial growth. And and also we can able to keep the lips and mucosa soft, clean and intact. And the third one is promote comfort and improve nutritional status by enhancing appetites. So if you give a proper mouth care, definitely we can able to promote the comfort level and the nutritional status. Definitely they will ask something for eat. And stimulate the blood circulation of gums and all oral cavity. If you give a proper, we can able to improve the blood circulation and eliminate the source of unpleasant smell. If there is a bad smell there, we can able to control it. So now coming to the common oral problems. So these are the some common oral problems which we have seen in palliative care. Let's see one by one. Dry mouth or painful mouth. So this is one of the most common problems. Halitosis, candidiasis, oral mucositis, and alteration in taste, excessive salivation. So these are the common oral problems which we have seen in palliative care. Let's see one by one. And this is xerostomia. So xerostomia, we all know that dry mouth. So if the patient is having some kind of medications can also cause dry mouth. So we have to check for that. If the patient is complaining of xerostomia, you have to check all the things. I'll come to you later on assessment part. And the second thing is candidiasis. So sometimes you can see that picture. Candidiasis is look like this. Sometimes it could be extend to the esophagus too. So that time the patients might be complaining of difficulty in swallowing. So that time what you have to check is, if the patient is complaining of difficulty in swallowing, you have to check whether the patient is having any oral thrush or not. And the third one is halitosis. That will be both affecting the patient as well as the caregiver. And mucositis. So mucositis, we all know that mucositis is also another problem. And who needs mouth care? We know a person needs mouth care, but a few person needs mouth care more frequently. Let's see one by one. Terminally ill patients, unconscious patient, the patient breathing through mouth, because terminally ill patients and unconscious patients usually they will breathe through the mouth, so that patients can develop dry mouth easily. So this kind of patient need more frequent mouth care. And post-operative patients, patient with infections and diseases of mouth, head and neck cancers. Just imagine see a buccal mucosa. Definitely, the patient need a frequent mouth care, because lot of foul smell and a lot of secretions will be there in that oral cavity. So we need to provide more that frequent mouth care. And the last one is patient on nasogastric tube feeding. If the patient is on nasogastric tube feeding, so often neglected their mouth, because nobody wants to look at their mouth, because the patient is feed through the nasogastric tube. So this patient needs mouth care. Uh, and the next part is assessment. When we see these kind of wet-borne patient or any patients, when we do the assessment, you have to check whether there is any cracked lips or not, dry or coated tongue, because as I mentioned earlier, so that picture is also I have shown you the candidiasis, because if they have a oral candidiasis there, so they have a difficulty. Sometimes they will be complaining of difficulty in swallowing too. So you have to check whether whether their mouth is having any coated tongue or not. And dry mouth also you have to check. And white curd like patches here also. Sometimes it look like a white curd like patches if they have a candidiasis. And ulcers in the mouth, you have to check whether there is any ulcer in the mouth, any redness or bleeding, and any pain in the mouth, because they are not able to swallow properly, and also they are not able to chew properly. So if they are not able to chew properly, you have to check the dryness. If they are complaining of dryness, definitely they will be having chewing difficulty also. Have to check for that. And anorexia, definitely if they have a poor oral hygiene, the patient does not want to eat anything because of loss of taste and all, something like that. You have to check for that. And then unpleasant smell. And the last two thing is medication history and the treatment history, because most of the palliative care medications, because which we are used most medications which we are using in palliative care can cause dry mouth. And so you have to check for that. And treatment history too, because if the patient is on maybe after chemotherapy or radiotherapy, usually stomatitis is one of the most common problems. So you have to check for that and encourage the patient. You can give some if they are able to take oral fluids, you can encourage to take it, but otherwise you have to identify the cause and treat the underlying cause. And the next assessment part is over. Now we can move on to the solutions used for mouth care. We are going to give us learn about that oral care, because how to give oral care. So we need a solution. Within the hospital, we have a normal saline bottle, and we will be using that normal saline. But you have to tell the patient and patient caregivers about how to make a homemade saline. The same, you can take water. So take a 500 ml of water and add 1 teaspoon of common salt. Boil it, cool it, and keep it covered. So that solution is enough for oral care. And the next thing is soda bicarb solution. Same 500 ml of water and add quarter teaspoon of baking soda. The same thing, you can boil it and cool it, and so that water you can use for oral care. So these things you have to educate the caregivers before they go home, because they don't know how to make a homemade saline. If this is cost effective, they can easily make it their own home. Okay, so this is very easy. So you have to educate them. And the few self-care education is also important. Here, brush the teeth. every twice a day, because we all know twice a day brush the teeth is mandatory. But if the patient, if a bedbound patients, you have to tell them they can use a soft toothbrush. And another important thing you have to keep it in mind is toothpaste left in the mouth can cause dryness. So usually sometimes they will be doing brushing, but some they will wash their mouth, but the toothpaste sometimes left in their mouth. So that can also another cause of dryness. If they are complaining of dryness, you have to check their mouth and rinse the mouth with homemade saline or soda bicarb solution after that after meal. And then tongue also they have to brush with a soft brush. Advise the patient to take plenty of oral fluids, that way we can able to prevent dryness. And also you have to think about the pineapple tin layer, because it contains an enzyme called anise. So this will improve the salivary that stimulate, that will increase the saliva, because this is a salivary stimulant. The another important thing is this is acidic. If the patient is having any ulcer in the mouth, it will be too painful, because it is acidic, and it will be very irritating too. And the next part is procedure. So now we understand that what are the common problems, who needs frequent mouth care, and how to assess the patients, how to make a homemade saline. And now we are going to learn about procedure. So if the patient is need an assistant, because for a paraplegic patients, they are able to move their upper part of the body, but they are not able to take the articles nearby. So what you can do is you have to make a necessary arrangements for that. So you have to tell the caregivers, because if the patient is on in a bedbound conditions, the caregiver, most of the place the caregiver himself or herself to make them themselves available all the time. But even if they are able to do something, but they are not able to do it, they are not they are not allowed them to do it. So that way the another problem is muscle wasting will be there. So that important message you have to tell the caregivers, whatever they can, they have to. So if they have to allow them to do it for their at least a self care. What they have to do is they have to arrange all the articles nearby and encourage the patient to do it their that oral care or self care, whatever they can. The same thing after that, so they have to you have to document it after the oral care, you have to document it well. And now we are move on to the oral care for an unconscious patient. We know within the hospital, we nurses how to take care of oral cavity and how to give oral care and all. So we have an arthroposis and all. So within when they go home, the caregiver is the primary person to do oral care for the bedbound patients. What are the difference? Is there any idea? Do you have any idea uh, for that? When they go home, what all things you will educate, or how will they do oral care? Do you give artery forces for giving oral care? Anybody? Because we have artery forces when they go home for an unconscious patient. I'm talking about an unconscious patient. Uh, yes, no, you don't want to give artery forces to the caregiver. Then how will they manage? they need to give oral care to their loved one, because they need a oral give oral care every 2 hourly or 3 hour 4 hourly. So how will they do it? Any idea? Back of spoon. Very good. Very good. As Hema said, you can use spoon. Okay. Let's see one by one. So you can use back the spoon handle of the spoon, or you can use brush also. You can remove the bristles from the brush, and then you can use, and ice creams. You can use ice cream sticks also. Here you can just see that slide. Within the what are the difference in the hospital and home care settings? In the hospital settings, we have an artery forceps and tongue repressors, because if the patient is an unconscious, they are not they usually they will not open their mouth. If you ask something, they will not open the mouth. We have an tongue depressor, and we will use tongue depressor for opening their mouth. Okay. So and also we have an artery forceps. We will, after that we will use artery forceps for cleaning their mouth. But in home care setting, we can use a spoon, or you can use ice cream sticks and gauze piece. In the hospital settings, we have a gauze piece. But in home care settings, if they don't have a gauze piece, then you can use a clean cotton cloth. And normal saline, we within the hospital, we have a normal saline, but you can make homemade saline in their home. And small Macintosh, we have a small Macintosh. They can use their own plastic sheets. Our aim is to prevent soiling of their bed sheets. And face towel, we can use any towel. And clean water is also need soft sticks. You can use the cotton that applicator or anything. So we need to, after the mouth care, we need to apply moisturizing lip agent to the lips to prevent cracked lips, and kidney tray or anything. So we can use for collecting the soiled cotton items, soiled mouth care things. So you can see that picture, handle of the spoon, no? So you can see that the spoon and the handle of the spoon is covered with a gauze roll. Procedure, again, we you have to explain the procedure to the patient and provide privacy, because usually for an unconscious patient, nobody's wants you. We know, we nurses know, we usually explain the procedure to the patients, even if the patient is an unconscious, but the caregiver doesn't know. So they usually doesn't they don't tell anything to the unconscious patient. They will be doing their own their self care things and all, without telling anything, because they will be thinking like they will not hear anything, that kind of things. Their mind always, you have to tell them, even if they are not respond, they can able to hear their hear us. So that important message you have to tell them. And always you have to provide privacy, provide a small Macintosh with face towel under the head. And we have a small video on that, I will show you that. Provide a semi-fowler's position and head turned towards the one side, so that all that secretions will rolling out. And use a padded tongue. So we need a 2 spoon. One the spoon we you can handle of the spoon is wrapped with a gauze piece, and tie it, that you can use for opening the mouth, and the another spoon you can use for cleaning the mouth. And another thing is, you have to soak the cotton balls with normal saline and squeeze out all the excess water. That is very very important, because the caregivers doesn't know. If you use that without squeezing, what happened, that water goes inside and it might be aspirating. So that we have to tell them. And another important message, you have to clean the mouth. First you have to keep the padded spoon and the right side of the mouth, and that time the left side of the mouth will open. That time you can able to clean the left side part, and then you can take the that wrapped spoon from the right side and keep it in the left side, so that you can able to visible see the right side part, so that you can able to clean the right side part, upper and lower chewing surface, and also you have to clean the tongue also. So after that, you have to clean with normal water also, because this normal saline water is very tasty. So you have to after cleaning with normal saline, you have to clean with normal saline, the normal water also. After that, you have to lubricate their mouth, so that we can able to prevent the cracked lips. And these are the common lubricants which we are using in palliative care: liquid paraffin, coconut oil, ghee oil, or Vaseline. So whatever, if they have anything in their home, they can use this kind of lubricants. So we have a video on that. I will show you now, and after that I'll go to the next part.
Patient. Mrs. Anna is suffering from brain cancer and is comatose. Mrs. Sophia is her caregiver. Miss Shanti is the attending nurse.
How is Anna doing today?
She slept well yesterday.
Oh, that's great. Can we clean Anna's mouth now? It is very important to keep her mouth clean daily. Even though she cannot respond, she can listen to us. I am Nurse Shanti. I am here to clean your mouth, Anna.
Articles required for mouth care. We need 1 Macintosh or a plastic sheet, 2 towels, 2 spoons or toothbrushes without bristles, a gauze roll or cotton cloth strips, a glass of homemade saline, a glass of normal water, Vaseline and swab sticks, a pair of clean gloves, a torch and a kidney tray. Raise the head end of the bed or keep 2 or more pillows under the patient's head. Take the Macintosh and the towel and place it behind the patient's head. This is to prevent soiling of bed sheets. Then spread the second towel over the patient's chest to prevent soiling of the dress. Wash your hands and wear clean gloves. Take 1 spoon and a gauze roll strip. Cover the handle of the spoon with the gauze roll and tie it. This can be kept for opening the mouth. Take the other spoon and wrap the same way. Here, the other end of the gauze or cloth should be kept long. There is no need to tie it. Take the wrapped spoon and keep in between the chewing surface of the teeth on the right side to open the mouth. Never use your fingers to open the patient's mouth, as they may bite your fingers. Take the torch and look for any white patches, redness, ulcers, bleeding, foul smell and discharge. Take the other wrapped spoon and dip it into the homemade saline or salt water. Squeeze the gauze well to avoid aspiration of solution by the patient. Remember, while cleaning, you should keep the other end of the gauze piece inside your hand to prevent accidental fall into the oral cavity. Clean the left side of the teeth, first lower chewing surface, inner side and the outer side. Then clean the lower front teeth, inside first and then outside. Then clean the upper teeth, inside and outside. Discard the used gauze after cleaning each surface and take a new gauze. Wrap it over the spoon and dip it in normal water. Squeeze well and clean the entire area so that the salty taste will subside. Then remove the wrapped spoon and keep it in between the teeth on the left side of the patient's mouth, and similarly clean the right side of the mouth as shown earlier. Clean the tongue from outer to inner parts, first with normal saline and then with normal water. Discard the used gauze. The cleaning procedure is over. Now apply Vaseline to the lips. Remove the towel. Replace all articles in its proper place and provide a comfortable position to the patient. Take home messages. Mouth care is an important part of daily patient care to prevent infections and foul odor. Remember to keep the patient's head tilted to one side during the mouth care. Do not use your fingers to open patient's mouth. Squeeze off excess water from the gauze before doing mouth care. Clean the mouth with clean water at the end of mouth care. To know how to make homemade saline, watch the video Dressing Materials and Solutions.
Thank you. I hope this video is helpful to everyone. So now we move on to the next part, care of eyes. This is a sort of brush of your knowledge, because we often within the hospital we know what all things we do for their patient, but when the patient go home, you have to educate the caregivers, because they doesn't know which eye is clean first and which eye is clean second, and where to wear. And so from inner canthus to outer canthus, and also they have to clean the cleanest eye first and then go to the infected eye. So that all things there you have to tell them, because before they touching the eyes, they should wash their hands with soap and water. That is mandatory, and they should do it. And within the hospital also, if you are going to discharge for a bed-bound patients within the hospital, if possible, you within the hospital also you have to that encourage them to do it their own, so that they can able to get an idea for take care of their loved one. And also you have to document it properly, and they have to use one soap for one stock. That is also important. Otherwise, they will use the same soap for the next eyes also. That way, there is a chance of the spread on the infection one eye to the another eye too. Coming to the care of nose and ear, always you have
वाली
to
गली है या और एक बेकल चौक है रिमन के उसके पीछे एक गली है ये तो गाड़ी नहीं जाएगी
sorry. Uh, did you hear that care of eyes? Please respond. Can't hear. Okay. Thank you. Thank you. So, care of eyes is very, very important, because this is a sort of brushing up your knowledge, because we know how to take care of the eyes, but the caregivers doesn't know. Here, we need to, what you have to understand is, you have to tell the caregivers the importance of hand washing. Before they touching the eyes, they should wash their hands with soap and water. That is mandatory. And the another important thing is which eye they need to clean first. If they or the one if the patient is having one eye infected, so which eye is clean first? So they have to clean the cleanest eye first, and then go to the infected eye. So that is very, very important. And the another important thing is they have to clean from the inner canthus to outer canthus. And the last important thing is they have to use one soap for one stock. So these all things you have to educate them. If possible, within the hospital also you have to encourage the caregivers to do it their own, so that they will get an confidence, and they will, when they go home, they will try to do it this way. And coming to the care of nose and ear, here also you have to explain the procedure and remove the secretions from the nostrils. That is important, because if the patient is on nasogastric tube, especially, you have to check their nostrils if there is any that or any secretions or any things inside the nostrils. You have to check it and clean it well. And the another important thing is behind the ear, because there is a chance of dirt accumulated behind the ear, and that can cause ulcer formation, especially bed sore. You have to check for that and clean behind the ear, that ear also. And the collection of wax is also another problems that might be affecting the patient, like hearing problems also. Sometimes that might cause pain also. So what you can do is you have to refer the patient to the ENT surgeon and do for the further take further management for that. You don't give apply any oil or any insert any stick for removing wax or things. You don't do it. You better you can refer to the ENT surgeon. Coming to the care of hair, because nowadays we usually do the sponge bath for a bed-bound patients. Nobody bothered about care of hair, but this is also mandatory, because nobody's because for a bed-bound patients, they need a hair wash, but the caregivers is helpless. The caregiver doesn't know how to give a hair bath for a bed-bound patients. Or you have to educate them when they go home. They can able to wash their hair, their loved one's hair within the bed, so they can. These all things. This is the easy method you have to. These are the easy methods you have to tell them, because they don't need a Macintosh for that. If they have a plastic sheets there, they can use their own plastic sheets. So our aim is to prevent soiling of bed sheets. No, so if we have two plastic sheets in their home, we can do hair wash in their home very easily. So what you can do is you have to be before doing that hair care, you have to plug their ear, because there is a chance of water goes inside the ear. So that we can that part we need to prevent. And also you have to think about the eyes also. You have to place a that cotton the gauze piece or a like a sponge cloth, that kind of materials you can put it in the put on the eyes, so that we can able to prevent that dirty things inside the entering into the eyes. And also you have to wash whatever they like, because if they sometimes they will be using soap, and sometimes they will be using shampoo. So you according to their preference you can use it. And after washing you have to remove the cotton balls from the ear. That part you don't forget, and you just educate them before they go home. And nail care also, this is also important, because the caregiver doesn't know how to take care of how to remove, how to cut the nails. If you soak the nail at least 55 minutes, so that the nails will become soft. So after that we can able to cut the nails very easily. So that part you have to educate them. If they are able to that soak their nails on, you can take a bowl with a warm water and put your finger nail into the water, and after that you can cut their nails. But when you cut the nails, you have to cut the free edges only, otherwise it will no, cause injury to the that beneath the part of the nail. So that so especially for a diabetic patient, so it is very important. You have to tell them that. And bed bath is also important. We all know that how to take give a bed bath, but what you have to educate them is they have to expose only a small area at a time. So that is very very important, because if the patient is in bedbound and unconscious, nobody is bothered about it. Is they will remove all the dress from the all dress the things from their body. They will be thinking like anyway patient is unconscious, no? But they inside their mind they can able to hear us, and they want to tell something but they can't. So you have to expose the only part, only small area at a time. Whatever area you need, they have to expose that part. Once they clean that part, they have to move the next area. So that part, that thing also you have to educate. And also they have to if they are applying soap, they have to remove the soap completely from the body, so that we can able to prevent dryness. And they have to clean from the cleanest part first and then go to the non-cleanest, because the upper part of the body we considered as the cleanest part. You have to clean the upper part of the body first and then go to the lower part of the body. And also when while they go doing the bed bath, they have to inspect the skin carefully, because if there is any colorful discoloration, any color change there, they can able to easily identify and prevent further deterioration. So that is also very very important. After that, they should apply some moisturizing cream and give a massage at least 3 to 5 minutes, so that we can able to improve the blood circulation, and that way we can able to prevent pressure sore formation. So here back here, I already explained. Morning you can give a sponge bath. That time itself you can give a back care also. But in between, at least 2 times you have to. While we change the positions, you have to give a special attention on that the skin, and then you have to give some back care to the patient and apply some moisturizing agent, so that we can able to prevent or improve blood circulation. If you not give a proper attention to the skin, what happened? Pressure ulcer. So pressure ulcer, we all know that pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence, as a result of prolonged underlived pressure. If there is a prolonged underlived pressure there is a chance of breaking down of underlying tissues, especially the bony under the or the bony prominence. So that is pressure ulcer. So if you give a good attention on for their skin, we can able to prevent these kind of complication like a pressure ulcer formation. So prevention is better than cure. So always whenever you have seen a bedbound patients, you have to think about a prevention of pressure. So position, you have to think about position change every 2 to 3 hours. They have to change that position. And even if the patient is in wheelchair, they have to relieve their pressure in every 15 to 20 minutes, and manage incontinence also. If they are able, if they are willing to put, if the patient is complaining of incontinence, if you can ask them whether they are willing on Foley's catheter. If they are willing to do it, you can do the Foley's catheterization. Otherwise they can use their own diaper. But if they are not affordable, they can use their own clothes. But the thing is, they have to change it if become wet. And another thing is special mattress, air mattress, water mattress, pillows, cushions, all these all things you have to think about. And nutrition, hydration, exercise. So don't forget about nutrition. So protein intake diet is also mandatory. They should take any protein contained diets. Otherwise, that the patients will get pressure ulcer. And hydration, exercise. If they are not able to move that. Individually, so you can do some maybe you can encourage the caregivers to do some passive exercise for their loved ones, so that we can able to improve the blood circulation, and we can able to prevent constipations too. and a massage. Whenever you have turned the patient from one position to another position, you can apply some moisturizing cream, liquid paraffin, or white petroleum jelly, or coconut oil. You can take it your own hand and apply on their skin, so that you can give some simple massage so that we can able to improve blood circulation. And always you have to think about the wrinkle free bed and nail care. If the patient has nails in their hand, they will sometimes they will scratch on their own that body, and that way the patients become develop pressure ulcer. So we all know that this is a small tip, SKIN, supporting surface skin inspection, keep moving, and incontinence or moisture control, nutrition. So this is that small tip, SKIN. I think you already heard this when while we doing the bed source session. So this is a small tip. You have to keep it in mind all the times. And coming to the next part, active and passive exercise. So exercise, if you do some exercise for the bedbound patients, definitely we can able to prevent contractures, and we can able to prevent pressure sore also. That way we can able to improve the circulation, no? And all we know all joints need physiotherapy, otherwise contracture will develop. And this is you have to educate the caregivers, because when they go home they are alone. The caregiver is the only person to take care of the loved one. You have to educate the importance of exercise. Coming to the catheterization, so this is catheterization part. We all know that Foley's catheter is a sterile tube that is inserted through your urethra and into your bladder to train the for training the urine. We usually, if the patient is in incontinent stage and sometimes retention of bladder there, that time we usually put a catheter for train the urine. So these are the types of catheter: indwelling catheter, and supra. We have a supra PB catheterization also. For indwelling catheterization, there are two different catheters we usually use: Foley's catheter and silicone catheter. What is the time duration for changing a Foley's catheter and silicone catheter? Duration of changing of Kalyani says 15 days for Foley's catheter. Kalyani? Okay, for Foley's catheter, 15 days. And Ashwati said Foley's 1 month and silicone 3 months. Okay. Any other answers? Jodi said Foley's 15 days and silicone 3 months. Okay. Any other answers? Okay, thank you. Thank you for your answers. Ashwati said Foley is 1 month and silicone 3 months. Why do you want to, what is the thing behind that? Why you want to, sometimes the caregivers could be asking like, they would sometimes they would be asking like, why do you put silicone catheter for 3 months? Lissy Mikhail said 1 month silicone 1 month. Some usually if you suggest silicone catheter for the caregiver, because the silicone is quite expensive, silicone catheters, definitely they will be asking you about why do you want to keep silicone catheter for 3 months. How do you answer for that? Yes, Vijayanti said Foley's 28 days and silicone 3 months. Why do you, why you want to keep silicone catheter 3 months? Because so Foley's catheter is made up of latex material, and the Foley's catheter is the silicone catheter is made up of the silicone material. No, because the Foley's catheter, the latex material is very easily to get infection, so that we need to change every 30 days, because every month we need to change it. But the silicone material is tissue friendly and less chance of infection. That is the indication, because that is the purpose. Because if anyone asks you to the silicone for silicone catheter, why do you want to keep silicone catheter through 3 months? You do. Why do you want to keep the Foley's catheter? Please, we can manage with the Foley's catheter for 3 months. So you have to explain for that. You have to give a proper explanation for that. If you keep a Foley's catheter for 3 months, definitely the patients will get a urinary tract infection, because that will getting very easy, because after 30 days, definitely the patients will get urinary tract infection. There is a more chance of getting infection. And if you are using silicone catheter, that is tissue friendly and less chance of infection. So that message you have to convey it. And the second thing is indwelling suprapubic catheterization. The same catheter which we are using for indwelling catheterization, you can use for suprapubic catheterization. Foley's catheter or silicone catheter, you can use it. Clean intermittent self catheterization is the third one, and the last one is quantum catheterization. So here I want to say something. Here we know suprapubic catheterization. Clean intermittent self catheterization is one of the important part you have to learn, because for a paraplegic patients, they are able to move their upper limbs. If they are usually when they become paraplegic, we put Foley's catheter for draining their urine. But if the patient is the patients will be on Foley's catheter some maybe years, sometimes months. But nobody is willing to expose their private part to other persons, because one of the nurse or a doctor need to change the catheter every month or every third month. For a younger persons, just imagine they are not willing to expose their private part, but they are helpless. They need to change their catheter. But if the we need to do it for that person. Definitely, we know this is an important thing. We need to change this, but you have to think from their side, and if they are able to do it, self intermittent catheterization, the plain intermittent catheterization, you have to encourage the patient to do it. Okay. For here we have seen many patients. When they come here, the major worry is to putting a catheter. So they need to expose their private parts to the female nurses. That all things, it will be affecting the patient emotionally. What we do is we used to do try to sensation of their bladder, and if they have some kind of that sensation, we try to remove the Foley's catheter, and we used to do use that same Nelcat for the draining the urine, clean intermittent self catheterization. So what the we have seen good result for that thing, because If we set these kind of things to them, they are very eagerly waiting to hear these kind of things, and they are very interested to do it their own. And what you can do is you can give a Nelcat and ask them to wash their hands with soap and water, and take Nelcat from the bag and apply silocaine jelly, lubricating jelly on the Nelcat, and they can able to clean before that they have to clean the private part with soap and water. Okay, so that after that they can remove, they can take a Nelcat from the bag, and then the lubricate the tip of the now that catheter Nelcat with the silocaine jelly and apply and insert into their urethra, so they can able to manage it well. So you have to think about that also, especially for a paraplegic patient who is young, and the bladder is having some kind of sensation there. You can think about that. And then contact catheterization, because if you are using clean intermittent like an LCAT also, then night time they are not able to get up in the midnight and do it is very difficult, so they are not able to. But so that time they can use contact catheterization for draining the urine. Coming to the bladder care, so this is when if a patient is on as Foley's catheter, we know this is one of the foreign body in their bladder all the times. This will cause a urinary tract infection. So if someone's develop urinary tract infections, what is the primary advice we give? You have to instruct the patient to take plenty of oral fluids. Okay, so this is also you have to apply for these kind of patients. We know these patients might have developed urinary tract infections. They should take oral fluids, plenty of oral fluids. Otherwise, the patients will get urinary tract infection. So that is the important things, the first instructions which you have to given to this patient. And the second thing is provide perineal care. So perineal care is also important, especially male patient. They have to remove they have to clean the foreskin also. They have to that remove the foreskin under the skin also. They have to clean it. Otherwise, there is a chance of dirt accumulated in that part and can cause urinary tract infection. And also that part is also infected, and ulcer formation is also will happen. So that is also that second thing is provide proper perineal care with soap and water. If they are able to do it their own, even if the patient is on Foley's catheter, they can wash their private part with soap and water, because for a paraplegic patient they can able to. So you can encourage the patient to clean with soap and water from umbilicus to the mid thigh, so that all area will clean well. And empty the bag when 3/4 full. So that is the another important thing. And they have to observe the urine color, and whether the urine is draining freely, is there any occlusion or any block or things, that part they have to check into. And encourage the patient for daily bowel movement. So the third important point is bowel movement. The first one is ask the patient to take plenty of oral fluids. The second important thing is perineal care, provide good perineal care all the time. And because at least 3 times a day they have to do it. And encourage the patient for proper daily bowel movement is also important, because if they have a bowel constipation, then what happen? If the patient is have a fecal impaction, what happen? The fecal materials will be compressing the neck of the bladder, so that the urine will leak out, or sometimes the urine will not be going out freely, so that the patients will develop urinary tract infection because of the retention of urine. And coming to the perineal care is also the same thing. They have to clean the perineal part after each urination and defecation. They can use soap and water, and at least they have to clean from the cleanest area to the non-cleanest area, because we considered as the cleanest area as the urethral area, and they have to clean from the urethral area first and then go to the perineal part. So we have a small video on catheter care. We will show you on that and then move further.
Articles required: a sterile tray containing 2 bowls and gauze pieces, a clean tray containing clean washcloths, jug with warm water, normal saline, 1 Macintosh, 1 small towel, a pair of clean gloves, a pair of sterile gloves, 1 kidney tray, adhesive tape and scissors. Greet the patient. Explain the procedure to the patient and take consent. Provide privacy to the patient. Wash hands. Wear clean gloves. Prepare water to be used for procedure. Test the temperature of water. Place the patient in supine position. Place Macintosh and towel below the perineal area of the patient. Remove anchor tapes to free catheter. Retract foreskin and assess for signs of inflammation and discharge at the catheter site. Wash tip of the penis using circular motion with soap and water. Discard the used washcloth. Then clean with a clean cloth. Replace foreskin to its position. Remove gloves. Pour normal saline into the bowl. Wear sterile gloves. Using gauze swabs dipped in saline, clean the catheter from the urethral opening outwards for 3 to 5 cm. Repeat again. Secure catheter to the thigh with adhesive tape. Remove used articles. Remove gloves and wash hands. Place patient in comfortable position. Document the procedure and findings. This completes the procedure for catheter care in males. Points to remember. Always wash hands with soap and water before and after handling a urinary catheter and urobag. Always ensure the catheter is kept secure to prevent irritation of urethra. Check for urinary leakage. If present, identify the cause and manage appropriately. Maintain a sterile continuous drainage system. Keep the catheter and draining tube free from kinking. Maintain unobstructed urine flow. Keep the urobag below the level of bladder at all times. Do not rest the urobag on the floor. Do not allow the urobag to fill beyond its 2/3 capacity. Prevent contact of drainage outlet with the non-sterile collecting container. Observe the urine color for identifying any infection. Place the urobag as shown in wheelchair, walker. To provide dignity to the patient, the urobag can be placed inside a cloth bag as shown. Patients should be encouraged to have a good fluid intake of at least 2 liters per day. Ensure regular bowel movements. Perform catheter care daily once and after bowel movements.
Okay, thank you. So next part is bowel care for a bedbound patient, they usually can develop constipation because lack of exercise, privacy, reduced food intake, some of the medications which we are using in palliative care, because now we know, you all know that one of the good medications for pain relief for a for the cancer patients, like morphine. Morphine can cause constipation, because one of the commonest side effect of morphine is constipation. So and also some other medications like amitriptyline, that all things can cause constipation. So these things you have to keep it in mind. The patients can develop constipation. So when we do the assessment, you have to think about these, that they have a exercise, they can able to do their exercise on, or if they are able to not do it their own, you have to encourage the caregivers to do it for their loved ones. And the privacy, always give privacy for that passing the stool, because when they defecate in between, open the door and ask them whether you defecate or not, they will not be able to. So you have to give a proper privacy for defecate on their stools, and for defecation. And if they are able to not take a food intake or able to take it orally, you have to think about that also. You, if they have any problems, you have to check and try to underline the cause, the manage the underlying cause. And medication also, if that particular medications can cause severe constipation, you have to think about the changing of medication. But here in case of morphine, you can't change the medication, but you have to manage the bowel. So you have to give some stimulant laxatives and add some stool softener, and also you have to think about other laxatives. So that all things you have to think it. And also you have to think about the suppositories too. And always you have to give time, as I mentioned earlier. And if they are able to take a fiber containing diet, you have to allow them to take it fully, because if they don't take any high fiber diet, can also cause constipation. And regular exercise also. And if they are not able to move go to their toilet, you can use bedpans. And also that time also you have to, if you give commode or bedpan, so it doesn't matter, you have to give a proper privacy for defecation. And from the gastrointestinal session, you have heard about spurious diarrhea. This is very, very important for a bedridden patients, especially because the patients usually, bedbound patients bowels not satisfactorily moved. That time there is a chance of fecal infection, and that leads to spurious diarrhea develop. Here there is a chronic constipation can cause spurious diarrhea. Sometimes some usually caregiver will be complaining of since last 2 days, the patient will passing the loose stool. So they might be thinking like this is a form of diarrhea. But if you take a proper history, you will get a good picture of the bowel movement and bowel history, so that you can able to identify whether there is any spurious diarrhea or not. If they have a spurious diarrhea, you have to do the per rectal examination and find out whether they have a balloony rectum or not. If the patient's the rectum is balloony, the indication of stool is obstructed in the high part of the intestine. So that you have to do one thing, you have to give high up enema. So you can insert a suction catheter into the anus, and through the anus. And as much as possible you have to introduce and give a sodium phosphate enema, to sodium phosphate enema at a time, so that the sodium phosphate enema goes inside, and the top of the suction catheter. From that part, the sodium phosphate enema will act. So we'll try to contract that the mucosa from that part, so that somehow we can able to manage the fecal impaction. And also you have to think about the stimulant laxatives and the stool softener for next few days. And no, you can continue the stool softener and stimulant laxatives, and you have to think about the suppositories for the next few days. So this is the last part, nasogastric tube feeding. We know that what is nasogastric tube feeding. So after the nasogastric feed, after you put a nasogastric tube to the patients, the caring of nasogastric tube is very important, because usually the patients who are having nasogastric tube feeding get aspiration pneumonia. So what is the problem behind that? If the patient is on nasogastric tube feed, often get aspiration pneumonia, especially bed mount patient. What is the problem? Why was it happen? Any idea? Anybody? Anybody? If the patient, my question is, if the patient is on nasogastric tube feeding, often get aspiration pneumonia, improper tube position, then feeding in supine position, okay, regurgitation, Hema said regurgitation again, okay, okay, micro aspiration. So yes, regurgitation. So if they regurgitate, what happens? We also often regurgitate, but we don't get aspiration pneumonia. If the patient is on nasogastric tube, what? Why? So here you have to think about the nasogastric tube. When we insert a nasogastric tube into their stomach, what happened? Our gastroesophageal sphincter will be open all the times. Okay. So here, if the sphincter is open, what happened? When they regurgitate, there is no sphincter. There is no cardiac sphincter there. No. So their food can easily go up. The patients can regurgitate easily. But for a normal person, we have a gastroesophageal sphincter or a cardiac sphincter there. So our the fluid will be, the food and other things will be there all the times, because our sphincter muscle is preventing for regurgitation. But in case of nasogastric tube, is there, so there is, the sphincter is always open. So that's why the patients, when the patient is regurgitate, that easily goes into the trachea, and that way the patients will get aspirated. No. So the patient, if the patient is aspirated, definitely the patients will develop aspiration pneumonia too. Okay. So here also you have to educate the patient about a proper hand hygiene, because before preparing the food also they have to wash their hands with soap and water, because if there is if they are maintaining unhygienic practice for preparing food, can cause diarrhea. So that is also important, and give a semi-fowler's or fowler's position for before feeding. That is the one important message you have to tell them, and try to prevent air entry to the tubing, that we can able to show them. while we feed, you can able to demonstrate to the caregivers. And before giving food, you have to aspirate the gastric contents and find out whether the tube is inside the stomach or not. And before giving food, that feeding, you have to grind the food items well and filtered. Otherwise, it will that cause blockage. And another important message, you have to keep the same after feeding. You have to keep the same positions. Just keep the patient the same position at least 30 minutes, so that if the patient is regurgitate also, it will not go inside. It will not go to the trachea. No, so that way we can able to prevent aspiration. And also you have to think about the oral care, and change the adhesive also important, because we usually stick the that nasogastric tube on the bridge of the nose, but you don't need to apply stick that plaster on the bridge of the nose all the times. You can stick either the side on that either right side of the cheek or left side of the cheek, so that we can able to prevent ulcer formation. So these all important message, important things you have to keep it in mind while we teach the caregivers about nasogastric tube feeding, especially position, and why that after feeding also they have to keep the same position at least 30 minutes. The message also you have to why they need to keep the position at least 30 minutes after feeding also, we have to tell them. Otherwise they don't do like that like this, so that patients will get aspiration pneumonia later. So we have a small video on that also. I'll show you that, and after that if you have any questions, please ask me, or you can put it in the chat box also.
Nasogastric tube feeding. Nasogastric feeding is given to the patient who is not able to take feeds orally. Prepare feed at home with what is available, like rice or ragi soup, vegetable and dal soups, milk, water, fruit juice. Strain well before giving the feed. Articles needed: prepared feed 200 ml, 50 ml syringe 1, 50 ml of clean water, 1 towel, 1 pair clean gloves, a kidney tray and adhesive tape. Greet the patient. Explain the procedure and take consent. Provide privacy. Position the patient with the head of the bed elevated at least 30 to 45 degree angle, or raise the chest with extra pillows. Wash hands and wear clean gloves. Place a towel over the patient's chest. First, check the position of the feeding tube. For this, pinch or fold the end of the tube to prevent entry of air, and then open the cap. Attach a 50 ml syringe to the nasogastric tube. Aspirate the stomach contents and verify the position of the tube. Return all aspirated gastric contents to the stomach. If the aspirated fluid is less than 50 ml, feed can be given. After the tube placement is confirmed, remove the syringe and close the end of the feeding tube. Then, remove the piston from the barrel of the syringe. Pinch the feeding tube and attach the barrel of the syringe to the tube. Then, fill the barrel with 25 ml of water and allow it to flow in by gravity by raising the barrel above the level of the patient's head. Pour prepared feed into the barrel when it is 3/4 empty. Give the feed slowly without air entry. Give a total of 200 ml of prepared feed. Total quantity of feed plus water should not exceed more than 250 ml. Flush the tube with at least 25 ml of plain water. Pinch the tube whenever necessary to prevent air entry. Remove the barrel and close the end of the feeding tube. The tube can be alternatively secured to the cheek to prevent ulceration to the surface of the nose. Keep the same position of the patient for at least 30 minutes to prevent aspiration. Replace the articles, remove gloves, wash hands, and document the procedure. Points to remember. If the aspirated fluid is more than 50 ml, skip the feed and return all aspirated gastric contents to the stomach to prevent fluid and electrolyte imbalance. If the patient wants to taste the prepared feed, allow him to taste it. Give feeds too early. Put the patient in a side-lying position for 30 minutes after giving the feed. This is to drain the secretions out of the mouth and to prevent aspiration. Oral cavity is often left uncared for in patients on nasogastric feeding. Always remember to provide mouth care at least 3 times a day. Watch video on oral care.
So thank you. I hope it is clear to everyone. It's the end of my session. And anybody have any doubts on this, please ask me. You all know that this is your last session. Your feedback is very valuable for us. If you have any comments or suggestions for this course, please feel free to tell us so that we can able to improve. Any questions? So please switch on your videos. I want to see you all. Any suggestions or any comments you have to tell some feedback from not today's class. I am asking about the whole session, FCPN, Foundation Course in Palliative Nursing. So you have to share your feedbacks. So also in this, can you put this chat under this site? Vinisha asking, ma'am, pending case study presentations. So your case presentation is here, but unfortunately you don't get time to present it, but we will be evaluating your case presentation and let you know. And okay. So thank you, Priyanka, for the kind words. Jodi is asking about the pending assignments and marks. Definitely, Sangeet will be giving your update, assignments update on that. Definitely, he will send your thing, the assignment parts, clearance and all. If you need to resend it, that also Sangeet will share it with you. No worry on that. Any other things you want to ask?
Please feel to unmute and speak. Please, we are eager to know your feedback on our sessions so that we can improve on our next section also.
Anybody? No. So how we collect our certificate?
It will be sent through the individual emails. You will get certificates through your emails.
Once your assignment is cleared, Sangeet will send your certificate to your email.
Is there anything else you want to tell us? You can chat as well. Okay, I think that's all.
Okay.
Okay, thank you everyone for participating and through our journey, supporting through our journey from the first session to the 18th sessions. Thank you, Shiba ma'am, for the wonderful presentation. That was a very wonderful presentation with the video also. Hope you all enjoyed and studied well. Let's see any other next program. Okay.
So thank you all for joining this session, especially foundation, the whole foundation course in palliative nursing. I am sure you have learned few things from here, especially palliative care, the concepts of palliative care and all. Try to apply your patient care, because that apply that principles in your patient's care, so that we can able to improve patient satisfaction, and we can able to improve quality of life of the patient and their family. Always you have to think about the psychosocial issues, don't forget about that, and the non-verbal communication, that things all you have to keep it in mind while we communicate these patients. So you always you have to keep it in mind whatever you have learned from here. And if you have any help, if you need any help, please let us know, and please free feel to ask us. We are very interested to help you. If you have any doubts, please ask us. Thank you once again. Best wishes. Thank you.
Thank you. All the best. Bye bye.